Um, we're going to go ahead and get started just so that we make good use of the time of the people that are here. So just to lay down some ground rules right off the bat, uh, I very much love dialogue. And so when I have done this training a lot in the past, I've been doing it in front of a live audience. And so it's been great to have the interaction. I'm hoping to have a similar level of interaction here. So please feel free to jump in that chat box. I'll be keeping my eye on that as well and answer any questions that you have along the way. Another thing that I have to say right at the beginning, particularly since this is public and because people can be watching this recording later, is that vision therapy should only be done under the guidance of a licensed optometrist. And so if you're watching this, this isn't to be consumed or used really unless you are employed or an optometrist yourself. So just to put that disclaimer out there. James was going to be here. He kind of is the one that has kind of spearheaded our webinars, especially since this is really targeted to therapists out there. And James is our certified optometric vision therapist on our team. He got stuck because of all the snow we're getting around here. He got stuck on the pass, and so he's not able to join us today. So that means it's just me. He had these beautiful slides all ready to show you. Rather than going that way, I'm selfishly not going to use slides and just teach this. So don't tell James this, but secretly I'm kind of excited because I love teaching this topic. And so we're going to just jump right in and do that. But I don't have any set up slides, but I think slides are kind of boring anyway. So we're going to talk today about extraocular muscles, and then we're going to talk about the innervation of those muscles, and then talk about why we care. All right. To do that, I'm going to kind of set us up with, a case that you have come in. A lot of us are working with people that have had head trauma or stroke or other things that can affect the brain. Other people have issues from birth that can affect the extraocular muscles. Duane syndrome is a classic example of that. But let's say you have a patient that you're working with and you're noticing that you just can't get this person to get their eye to deviate outward. You've got a little bit of anisotropia. I think it's really important for a therapist to know the difference from just a standard run-of-the-mill esotropia and one that's had some kind of an issue with the cranial nerves such that they can't get full function there. So that's really why this is so important, I think, is that not only is it good for you to understand how the extraocular muscles work and how the eye actually moves with those muscles, but when they're not working, why that's happening, because it's going to affect the types and things that you can do in treatment. Okay? So starting right off, let's get my beautiful drawing up. You'll see I'm an amazing artist here. So you've got an eyeball, a nose, and an eyeball. Okay? We're going to use this eyeball here really to do our drawings on, but I just want you to know the reference points. So this is going to be what we call lateral and medial. So this is the middle of the body, right? And so we call this medial or middle. And then this over here is lateral, okay, over to the side. And that's going to be important in the naming of these muscles that we have. So let's go ahead and start putting muscles on our eyeball. Okay, so first thing that we have, we're going to go over the most standard ones here. Okay, so our eyeball has here these four muscles. That kind of makes sense that you would have those four to move up, down, left, right. Okay. And I had this really cool eye model but I started looking at it. I didn't really like how they were representing the muscles. And so you don't have a model in front of you all the time either. So what I found works really well is to use your hands. This is going to be our eyeball, and you can get that out. Also, what might be helpful to you right now is just to go to Google and type in extraocular muscles, and then go to images, and you'll see a bunch of different images that, and that way, especially when we get into the superior and inferior oblique, it'll be helpful for you to be able to image that a lot of different ways. So here we go. Let's talk about this first one, which is the superior oblique, okay? Superior, oh, I'm sorry, I said oblique. I meant superior rectus, okay? So with the superior rectus, this muscle is attached right on the top of that eyeball. And so what does it do? It helps pull the eyeball up, okay? And so that's the job of the superior rectus. So I guess you could probably guess the function of the inferior rectus, right? Touch down on the bottom, pulls that eyeball down, okay? Same here, we have lateral rectus and then medial rectus, okay? So those are all pretty straightforward. So the lateral rectus attaches over on the side, is going to pull that eyeball out, and then the medial pulls the eyeball in, okay? So I'm hoping you're using your fist and kind of visualizing that, because it's going to become real important as we go to these next two. So we have the superior oblique, okay? You can see this is a little bit of a different muscle. Okay, so this muscle, let me do it this way. Okay, that right there is what we call the trochlea, okay? And it's just this, essentially a ligament, a tissue, and that muscle runs through that and then attaches to the eyeball, okay? And so if you can think, if this is the medial side, this is my eyeball, it's running this way, it kind of goes around this pulley system and then attaches to the eyeball, okay? So if it's running around like this, it also helps to pull that eye down even though it's on the top. Does that make sense? Okay? So it's pulling this way. And part of that job then is as we turn our eye this way in, okay, just the way that the way that the muscles are placed without that superior oblique there, okay, and it turns, your eyeball will kind of flow upwards. And so part of its job is to keep that eyeball level as you're turning your eyeball in, okay? So you can imagine if that's not there, what is that going to look? If whenever that patient looks medial, you're going to see this little bit of an upswing there, okay? And that's one of the best ways to tell that you have an issue with a superior oblique, because you'll have that patient follow along the midline and you'll see a little bit of an upswing there like that. Okay, so that is our superior oblique. Finally, we have our inferior oblique, and it's kind of weird too, because it comes from over here, but it runs behind here and attaches way over here, okay? And as such, because it's grabbing kind of behind the eyeball there, it helps pull the eye up, okay? So that's the inferior oblique. Any questions so far? Looking at the chat here, I'm not seeing anything pop up, but hopefully this is making sense, okay? So we have these different muscles that help do these different parts to help the eyeball to move correctly. And obviously you have the same thing over here. Again, this would be medial, because this is the nose, medial, lateral, superior, inferior, and then your superior oblique on this eye would come here, okay? And the inferior oblique would come from here and attach over on this side over here, okay? So that's, that's the 6, okay, muscles of the eye, or the 6 extraocular muscles. Extra meaning outside. So outside of the eyeball, ocular muscles. So now the fun thing goes is, well, how do we move these? Okay. With all of our muscles, to get them to contract, there has to be a nerve that innervates that muscle. So there's nerves that go to that muscle fiber and tell it to contract or relax. Okay. And those nerves, we have 3 nerves that are involved in this, okay? So we've got the cranial nerve 3. Let's do that in black. Cranial nerve 3, cranial nerve 4, and cranial nerve 6. Okay. So starting with cranial nerve 3, this is the one that does the biggest chunk of the work. Okay. It controls the medial rectus, it controls the superior rectus, it controls the inferior rectus, and it controls the inferior oblique. Okay. So I'm going to put a 3 by these. Again, you can look on your drawings. They may have this labeled as well. This is 3. This is 3. Okay. So it's doing a lot of work there. Now, you notice that there are 2 that are still, we haven't labeled yet. Okay. So the cranial nerve 4 goes to 1 muscle by itself, and that's the superior oblique. Okay. Cranial nerve 6 innervates the lateral rectus. Okay. Why is it done this way? I don't know. Okay. But this is what we know of where these cranial nerves are innervating. And so we know if something happens to one of those nerves, okay, what the effect is on the eye. So let's start first with the easiest one, which is cranial nerve 6. So we've got our eyeball, right? Cranial nerve is the one that pulls on the outside. I guess I could do it this way. Okay. So that's the lateral rectus. And so if all of a sudden this is not able to pull, what direction is that eye going to go if it's not working? It's going to turn inward just a little bit. Okay. So it's going to look like a esotropia because this one's no longer functioning to keep it straight. Okay. Also, when we go to try to pull outward, you're going to notice that it can't go. Now, people that just have general esotropia, unless it's like really big and it's been there a long time, generally speaking, if you cover up their eye, okay, this eye is going to start working, okay? Because basically, in an esotropia situation, you've got the good eye, okay, that's doing all the work, and this one is being suppressed or turned off, okay, and not doing, it's not participating as much. So when we take out the strong eye, then all of a sudden this one has to wake up and start working. And so when you cover this, you'll notice someone with just a standard esotropia will be able to just move that eye out, no problem, okay? Now, someone, if they have a cranial nerve 6 issue, and where we see this a lot of times is in stroke, diabetes as well, severe diabetes can affect cranial nerve 6, so you'll see it in that case as well. And you'll see that eye, when you try to look this way, it's not going to fully go out, okay? it's going to get stuck right about looking straight at you and won't be able to move that way. And so what we call that is non-comitant. Comitant means that the strabismus or esotropia in this case is the same in every gaze, okay? So that eye is just a little bit inward or a lot inward in every single gaze. If you notice in this, if this muscle's not working, when I look over to the left here, then both eyes are going to be pointing just fine this way because nothing's wrong with that medial rectus. It's going to be able to move just fine that way. But if on the other hand, I've got to try to move this way, then you're going to notice a big esotropia whenever I'm looking off to the right, okay? And so because of that, that's what we call non-comitant because it's a different amount of esotropia, which is almost, it should be like 0 this way, and then a huge esotropia when we look off that way. So that's what we call non-comitant versus a comitant esotropia. And this is a good time to talk about something else, which is the difference between a palsy and a paresis. Almost always in medical school, in optometry school, we're talking about palsy. A palsy essentially means that that nerve is totally unfunctional. There's nothing there, okay? And so if there's nothing there at all, then there's not really much that we can do because typically we're talking either a lack of blood flow that's cut off the ability for that nerve to work, or there has been something mechanical. They had trauma to the brain that hit that nerve so that nerve is no longer able to function. If any, Megan, the medial rectus was cranial nerve 3, okay? Oh, cool. So Sarah says that she had a patient today with a 4th nerve palsy, and so we'll get there today, okay? So a palsy just means that is no longer functioning. And really, if it's a full palsy, unless that we think that this is maybe just a recent head trauma and that there's some regeneration going, and so we may be able to get some function back. But generally speaking, if it's a palsy that's been around for a while and we don't see a reason for that innervation to start again, there's not much we can do in vision therapy, okay? What we would be doing in vision therapy is then helping them to make accommodations for the fact that they can't look this way with this eye, okay? So there are lots of different things, and your doctor can go over that you can do to accommodate for that, including some patching, some other things that you can do. But not much we can do if it's a full palsy. But in most instances, when we're working with a patient, it's not a full palsy. It's what we call a paresis. A paresis is part function, okay? So that nerve is working, but it's not working to the level that it should be working. If that happens, then we get some function, and so we can increase and magnify or get the most efficiency, the best effort that we can out of that partial function. And that's something we definitely can do in vision therapy. Now, interestingly, when you talk to most doctors and they talk about a palsy happening, you typically don't hear doctors talking about paresis. They say, oh, patient, I'm sorry, you've got 6th nerve palsy, not much you can do about that. Or you've got a 4th nerve palsy, sorry, your eye is just going to be that way. The beauty is very rarely is it a total palsy. And so we've had many patients in our office who they've been told that there's nothing they can do for that it's just going to be that way the rest of their life. And we've been able to get a lot of function back. One of the muscles that is most commonly affected is that superior oblique. And people get a lot of double vision when they're looking off in the distance because that eye's going to be raised up a little bit. So they're getting this double vision. And I've had many doctors say, sorry, you're just going to always have that. They try to use prisms and other things to help them. But we've gotten to where, I'm thinking of a lady in particular right now. She loved to go out and go skiing, water skiing with her family. That was the big thing they did. And she just really struggled because everything was double when she looked way off in the distance. Just a lot of even driving and other things became very difficult for her. And she was told, sorry, there's nothing you can do. Hopefully we can get some prism, but the prism never really worked very well for her. But we were able to work with her and found that it surely was actually a paresis. And working with her, we were able to finally get that function to the point where she had control enough to keep to, I'd say 80% of the time, she no longer had that double vision. If she got really fatigued or whatnot, it would show up, but it gave her so much more ability and so much more control in her life to be able to have that function. Okay, so that's the difference between a paresis and a palsy, and why we would work with these people that have these issues with these cranial nerves. So we just done talking about cranial nerve 6, the lateral rectus. So we're kind of working backwards up our list, and so now let's go to that superior oblique. Remember that oblique is coming this way and it's helping keep that eyeball down. So when it stops working, that eye starts to come up just a little bit. And so they get, when they're looking straight ahead, they're going to get just a little bit of a vertical displacement. But if they're looking off to the side, okay, when they go medial with that eye, then that eye goes way up because it's no longer able to keep that eye down. Remember, we talked about how in that gaze, it helps keep that eye down, and it's no longer able to do that, and so it swings up. So when they go to medial gaze, they're going to get a big vertical disparity between the two eyes. Okay. Okay. Let me just check over at our comments here. Sarah says, I've been doing therapy with them for over a year, and we've seen some ranges come back. So there's a great example. Says Dr. Andrew was happily surprised by this. And yeah, great example where, yeah, cranial 4, they were told it was a palsy, but certain, it was an actual full palsy, it was paresis, and so they were able to get some of that function back. So with that, so just kind of thinking through that superior oblique one more time, I've been showing you with the right eye, but let's look at the left eye just so that you're able to think through this right? Medial means towards the nose. So with the left eye, you've got the muscle that's coming in and attaching, same thing. So when you watch those eyes, this one eye is going to swing up this way. So when they're looking off to the right with a left superior oblique paresis or palsy, they're going to have more double when they're looking in right gaze. When you have a right superior oblique palsy or paresis, and then you look to the left is where you're going to see that big vertical deviation. So that's where they're going to have the most difficulty, is when they're looking at the opposite direction of the eye. You can think of it that way. Okay, so if I'm right eye and I'm looking to the left, I'm going to get a lot of double. And if I'm a left eye paresis or palsy and I look to the right, I'm going to get a lot of double. Okay, that's confusing. So please go ahead, like I said, put any questions, or if you want me to go over something again, let me know, okay? But that's what happens whenever we lose the function in that muscle. And so you'll see a little bit of a vertical. Again, this is a non-comitant vertical. So we typically call that a hypertropia. And it's a non-comitant hypertropia because that amount of hypertropia is not the same in each gaze. It's very different depending on which gaze that we're looking. Okay? So non-comitant hypertropia with the superior oblique. Okay. The superior rectus is a mess, and we rarely see this because of where the nucleus or where that nerve originates. It originates back way down deep in the brain, in the brain stem, actually. And so typically, if you get something happening to that cranial nerve 3, that person is not functioning very well because it's hit some core things. Our brain stem is where core function is, like our heart and just breathing and those types of things, okay? So if they get a cranial nerve 3, a lot of times there's other more significant issues going on, okay? I'm not going to go into exactly how all this works, but you can kind of, well, I think we can kind of think through this, okay? If we no longer have our medial rectus working, which way is that eye going to be? It's going to be out, okay? And if we no longer have these ones working, top or bottom, or this one that helps raise it up, and this one's pushing it down, that eye is going to be looking down and out. So with a cranial nerve 3 issue, we talk about the eye being down and out, okay? I haven't seen a major, like a complete palsy of a cranial nerve. Well, I take that back. I have seen them, but they came in a wheelchair. They were nonverbal. And like I said, they're really, I was able to tell them that I didn't feel like we were going to see much improvement with that. I have seen a very minor, several minor cranial nerve 3 issues, okay? So just slightly down and out, or they can even kind of pull it together, but just when they're fatigued, that's when it starts to double on them a little bit. And that's definitely something that we will work with. But that's important for you to know as a therapist, because this isn't just one muscle that's not working. You've got 4 muscles that are no longer working like they're supposed to, okay? So you're going to want to work in every gaze, kind of working all directions, trying to get that to come back. Versus like a cranial nerve 4 issue, if you're looking off the distance, you've got a little bit of a double, you help pull them together, because that's where it's going to, where they can do it better is in primary gaze. If they can't even do it there, I might even move a little bit off, okay, away from the nose, and they should be able to get better fusion there. But we're going to start there and start moving towards the nose. So the more they move towards the nose, the more double you're going to get, right? So you always want to start where they are and take them where they ain't. That's a Maples saying, right? So where are they? Well, we can get fusion looking straight ahead or a little off. So we're going to go and get fusion there and then start to work where it's more and more difficult. And so we started, particularly with this lady I'm thinking about, we were able to finally get fusion in central gaze, and then we would start to work more and more off into left gaze, okay, or the gaze towards the nose. And we could do that several different ways, moving the target, right? So the target is off, so they're having to look off that way, or just moving their head, okay? You move your head, then you've got to turn that eye inward as well. And so that's one way that we would work on that. Lateral rectus, okay, cranial nerve 6, same thing, very easy. You're going to be just working, trying to get that eye out. Eye stretches are a good one for that one. Just keep pulling and trying to get that eye to go outward, okay? I'm going to pause real quick. This is a great time again for people to jump in and ask questions if you have any. But that would be what I would be working on with someone that has a cranial nerve 6 issue, is that I would be working on trying to get that eye to come out, and then fusion here, and then starting to move toward fusion off in that lateral gaze, the outward gaze. So probably a good time to stop, rewind, and review, okay? That's the hard thing with this, is there's a lot of information here. So I want to be able to go back and review. So in your mind right now, I want you to think of the 6 extraocular muscles, okay? If you've got other staff members there, this would be a great time for you to tell your neighbor, if you can name all 6. Okay, I'll give you just a minute here to see if you can, in your head, name all 6 cranial nerves. And I should do this, right? So you can't see. Let's see if I have something I can use. Okay. I don't want to erase it in case we need it again. But can you name all 6? Okay. And how'd you do? Superior rectus, inferior rectus, lateral rectus, medial rectus, and then the superior oblique, and inferior oblique. Okay? Now, here's my, you know what? I am just going to erase it. Let's see how we do, okay? So we named our 6 muscles. I want you to, in your head, tell me, okay, if this patient, you see a diagnosis of a cranial nerve 4 issue, what muscle is it affecting? Okay, hopefully you said superior oblique. Okay, next one. What would you expect? What muscle or muscles would you expect it to affect if they had a cranial nerve 3 issue, palsy or paresis? Which muscles is it going to affect? Tell your neighbor. Maybe write it down if you're by yourself. Okay, so it's going to affect superior, it's going to affect rectus, inferior rectus, medial rectus, and the inferior oblique. Okay, so it's going to affect 4 muscles with that cranial nerve 3. Okay, and now last one. What would you expect? Which muscles are going to affect if they have a cranial nerve 6 issue? Answer should be lateral rectus. Okay, now how would you expect the eye to be posturing? If they have a cranial nerve 3 issue, where would you expect that eye to be? In, out, up, down, what would be happening with that eye? You should say down and out. Remember, it's affecting a lot of different muscles, particularly that medial rectus isn't there and that superior oblique is working overtime. And so it's down and out. Okay. If they have a cranial nerve 6 issue, cranial nerve 6, okay, talked about the lateral rectus. So where would we expect that eye to be posturing? Where would it be? Tell your neighbor. It's going to be a little bit in. Where's it going to be worse? Okay, out gaze or in gaze? It's going to be worse in out gaze because they're having a hard time looking. They can't get that eye to pull out, and so they're going to have a harder time moving it away from the nose. Okay, and finally, if they have a cranial nerve 4 issue affecting the superior oblique, where would you expect to see that eye posture? And in which case is it worse? Okay, again, it's nice to use your hand. Just think it's not, this one's not able to pull it down, right? So if it's not pulling it down, it's going to flow up. So it's going to be a hypertropia, and it's going to be worse in medial gaze. Okay. That's essentially what I had to share today. And that's about how long we like to make these, is about 40, 45 minutes. I don't want to bore you too much, but keep you actively engaged. Hopefully that was helpful. This is the type of material that we will be covering in our Vision Therapist 201 course, which we are working on and will be coming out sometime here, hopefully in the near future. But for those of you that are wanting, again, maybe need a little bit more of just kind of the basics We have our just regular vision therapist training course. It really takes someone from that knows nothing to really having a good concrete knowledge of what they need to know to be able to do well as a therapist. My earphones are beeping on me. Hopefully I don't lose audio here in a second. So any other questions out there? Wait just a couple more minutes. If anybody that's on, if they want to comment what they learned, what was the big takeaway, something that they'll be able to go and take this to use on Monday when they start again. Is there anything that's new that you learned? Here. Tyler says everything over his head. That's okay. Again, thank you all for joining. I hope that this has been helpful to you. We're trying to do these once a month, and so we hope that you'll join us again the next time. If you have any needs for any equipment or training or consulting, those are the things that we love to do here at Emergent. Please give us a call. We'd love to be able to help you there. Thanks. Have a great day.